So I'd like to introduce the person who's going to chair this panel, and that is Beth Finkel, who is the State Director of AARP New York. Thank you. And Beth is a fierce advocate for the 50+ population, fighting for the rights of 2.6 million members of AARP in New York State alone. They have legislative initiatives that she'll talk a little bit about, but they are one voice, but probably the most powerful voice advocating for seniors all across America, and in particular here in New York State. So with that, Beth Finkel.
So I think I'm going to do the same thing as the Albany County exec and stand here with a mic because I'm not tall enough to see the screen down here from behind the podium. Anyway, thank you all. Special thanks to Lou and Peter and Beth for inviting me here today. We always love to be part of this event because of all the great education and outreach that happens, and also the sharing from different disciplines, which is just so valuable. So I'm going to just start off on this panel today, just to give you a little bit of background on some demographics, which I think might be interesting to you. So good, there we go. So we recently commissioned a study with the Center for Urban Future, and we asked them to analyze the data from the 2010 census to the 2020 census and what that meant for the aging population of New York State. So you'll see on that first slide, Jonathan Bowles' name is there because he's the executive director of CUFS. And I want to make sure to give him plenty of credit for this because it was his hard work that gave us this great data. So here we go. So are you ready? A little shocking. 65+ in New York State. You can see the 2001. You can see the 2011, and then you can see the 2021. And this is more than just a regular trend line. I think this is quite extraordinary. So we're talking about it's a 30% increase, actually 31. And then if you look a little bit deeper and you compare it to the under 65, that number is really pretty shocking, right? Because the 65+ went up over 800,000, but the under 65 went down over 444,000. So that kind of explains to you some of the things that we'll be talking about: worker shortages, right? And how to get employees in place where we need them. And also to show the stupendous increases that we're going to be seeing in the trends going forward in New York State. So here, this gives it to you again. This gives you our favorite pie charts, right? And you can see it jumped from 14% of the population to 18%. And now, for those of you who like to know what's happening in your own home counties, I didn't list every counties, but I thought I'd do some dramatic ones. Anybody here from Saratoga? I'm sorry, folks, you win the prize, but you probably already know that because you're in senior services. So you know this. You could probably write this chart without getting the data back, right? Dutchess, anybody from Dutchess here? 37% increase over 10 years of the 65+ population. I mean, that's really extraordinary. Orange County, I can yell them all out. I'll just yell out Albany, almost 32% increase. Rensselaer, 30%. Rochester, I'm sorry. Where's the Saratoga folks? You don't win. Rochester wins. Really sorry. Okay, so then let's talk about older immigrant population. Again, foreign-born population of the 65+, okay, rose 42%. That's a very large number. And the US born rose 26.6. So for all of you who are out in the community, you know what this means. You know what it means about being culturally relevant. I don't have to explain that to you, but it also talks about the need for people being able to speak many languages, because that's what people are going to need, or they do need right now. And again, I'm just giving you this by counties. Oswego here, that was like an outlier to me. Where did that come? 67% increase in older immigrants in Oswego County. Something in the water? I don't know. What is it about? That people want to come and live there. Then you can see Queens, which not surprising. I think we all think about Queens as that kind of a population. Albany, 56%. And then living below the poverty line. And I know this is something that you're all interested in because again, it coordinates right back to your work. 2011, 300,000, and now 416,000. And if you'd like these, I'm sure, I know Beth has these slides and she can send them out to folks if you need them. Val says, yes, please send them out to her, please. Poverty rate for older adults, again, looking at locations. Rochester, I think we all know there's been a lot of struggle with in Rochester, and you can see it right here, the differences. I'm not going to call it out to you, but you can see the numbers are really striking. And again, a few more. Oswego, you got a little bit better here. Okay, and then poverty rate for older adults by race and ethnicity. So among Hispanics, it's 23.5% are living below the poverty line in New York State. Asian, 19.5%. Black 16.6 and white 8.7. So Valerie's talking about disparities in her slides. There's a good reason for that. And that's it. I do have a longer that goes into much more detail, but I didn't want to take up more time. But I thought to really stage the call, the panel that we're going to have now, it would be really important for you all to really understand what we're all dealing with, and that it's not just this is what you think you're seeing anecdotally. Now you have the real data to show that this is actually what is happening all across New York State. So I'm really proud to be part of this panel of industry leaders. I know you've got all their resumes. I'm going to do a little bit of shout outs, but what I love the way this panel is set up is that you're going to get 4 totally different perspectives from 4 totally different workplaces. So you're going to get it from nursing homes, home care and hospice programs, insurance divisions, and we even have an emergency room doctor with us, I understand. So you can come up after if you got an emergency for us. So we're gonna start off with Larry Slatky, who he got a shout out before from the Albany County exec. I thought he said you're retiring. I got that wrong. He's moving to Long Island, folks. That's what he told me. So he is still, though, the executive director of the Shaker Place Rehabilitation and Nursing Center in Albany. He's been there for, you've had over 50 years of experience in healthcare. You might have to be my new go-to person. And then after Larry speaks, we're going to go to Michelle Mazzacco. Did I get that right? Good enough. All right. She's the Executive Vice President of Continuing Care Network with St. Peter's Health Partners. She's been there 37 years. I should have said I've been at AARP 27 years. So these guys have me beat. And she leads all their continuing care services. And then we're going to go to Dr. Matthew Miles, our ER doctor, but he's currently advising on the expansion of VivaLynx, which is a healthcare tech platform. I think all of us want to learn more about that. So I'm very excited to have him on the panel. And finally, Jeffrey Collins, who's Vice President Government Programs and Outreach and Marketing, I think you told me too, right? For MVP Healthcare, and he's got 25 years experience. So you're behind me on the line there. Okay, and he's going to talk about their experience with Medicare Advantage and Medicaid and all sorts of other pieces. And I think it really wraps around what Valerie said and what the legislators were here earlier. So without further ado, what I'm going to do is I'm going to start off asking each of them to briefly talk about their perspective on long-term care and the services that are needed and how we could move forward in this sphere. And then I've got a few questions for you. So I'll let you start, Larry.
All right. Thank you, everyone. Good afternoon. It's really a privilege to be here today. And it's even more of a privilege, as I got to say this, working at Shaker Place, which was really a gorgeous long-term care facility where the county, as mentioned by our executive, invested over $80 million in a renovation to make our nursing home like a home. And it wasn't for government support, those type of renovations, in all honesty, do not happen. The average in nursing home capital reimbursement, and just so that you understand how capital reimbursement works for nursing homes, if you invest capital, okay, into your nursing home, it gets reimbursed over a period of that bond or mortgage. It could be 20 years, 30 years. So you get that money back over a period of time. But in order to invest that money, you need to have the money. The benefit of being a government employee and owned and operated by Albany County, the county executive could request it of the legislature. He goes to the bank, so to speak, signs his name and gets a bond for $80 million. And then it gets reimbursed over a 20 or 30-year period. The average capital reimbursement for nursing homes in the state of New York, so you understand how many dollars have been invested to repair or fix or renovate nursing homes, is around $9 a day in capital reimbursement. Our reimbursement after this renovation took place is over $80 a day. So you get to see the difference of a renovated nursing home and the capital reimbursement, or more honestly, how little nursing homes have invested in their day-to-day renovation or in their environment. So I think it's also important to understand what's been going on in nursing homes. There's a lot of legislation out there. A lot of it's being argued by the association. I don't want to throw a lot of numbers at you, but I just want to at least make a few statements that I wrote down so that you could see where nursing homes are going. And I should point out that 72% of the people living in nursing homes are paid for by Medicaid. So that's 72%. So therefore, 28% is paid for by other sources, whether it be Medicare, private pay, HMOs, et cetera. So the government is paying 72% of the stay of a nursing home resident. So if that reimbursement is not where it needs to be, it's very difficult to hire staff to provide the services that the regulations mandate, or to implement regulatory requirements that you want to provide quality of care. It becomes extremely difficult. Just to give you an understanding about Medicaid, the average Medicaid reimbursement in the state of New York is around $230, $240 a day, somewhere in that neighborhood. You could stay here in this hotel, and the average stay is around $250 a day. And you're getting housekeeping services. Nursing homes are getting reimbursed approximately $230 a day, and we have to provide 24-hour nursing care, RNs, LPNs, CNAs, housekeeping, 3 meals a day, therapy, recreation, okay, maintenance services, and I could go on and on and on, okay? So how the nursing homes make up that shortfall? In order to make it up, you have to have a large, or large as you can, Medicare population, which pays approximately $500 a day, or private pays, which pay also somewhere between $450 and $550 a day. That additional revenue, okay, is utilized, in all honesty, to subsidize the Medicaid rate, which is underpaid to nursing homes for years. Let me just throw some statements at you right now. New York State Medicaid rate hasn't included a trend factor, cost of living, since 2007. 2007, nursing homes did not receive the trend factor. Cumulative healthcare inflation costs are estimated to be 50% from 2007 to 2022. New York nursing homes costs per day have increased 34% from 2008 to 2020. Note that this doesn't include 20, 21, and 22. New York State was the only state to cut nursing home rates during the pandemic, while other states increased their rates between 5 and 20% during this same period. Minimum wage mandated increases were 85% to 110% from 2008 to 2022, fueling wage increases for all nursing home staff. Nursing home wages have increased 25% to 30% in the past 2 years due to price gouging. There's not enough supply to meet demand. And by the way, there's legislation out there which virtually 95% of nursing homes cannot comply with in the state of New York, of a mandate of 3.5 hours of care per day per resident. They also created at the same time that 70 is called the 70-45 rule, where 70% of your revenue, that's total revenue, private, Medicare, and Medicaid, it has to be utilized, okay, for services to the resident, and 40% for staffing. So it's mandated, okay, now, even though no one really could implement those regulatory requirements in a nursing home because they don't have the reimbursement to do so. 75% of nursing homes can't meet minimum nursing staff requirements due to poor reimbursement and workforce shortages. The associations have asked, okay, the governor, when she did her budget, for a 20% increase. We would really need a 40% increase in Medicaid just to break even. In her budget, she only put 5%, but it's 5% of a trend factor that we got zero for the last 14 years. Due to a lot of letter writing, okay, to legislators, they were nice enough to increase that 5% to 7.5%. So you could see there's still a huge shortfall between what Medicaid is paying nursing homes and the care that they're mandated to provide. Unlike other industries, nursing homes have no payer source to pass on, meaning when there's additional costs, whether it be linen costs goes up or food costs go up, you could pass that on to the consumer. Nursing homes can't do that. Their Medicaid rate is mandated and put forth by the government. This is what you're going to get. We know that on January 1. Medicare does the same. The only one that you could adjust are private pay. And then those are limited because people will have ways to secure through estate planning and other ways to secure those family assets. So even though there's a 5-year look back, it's still extremely difficult to admit private pay residents. And in all honesty, that money, that additional money just makes up the shortfall that Medicaid is not paying for the care of 70% of those who living in nursing homes. Being a government entity, which we are, the county, okay, Albany County, has subsidized, okay, our increases to, of care cost, okay, to the tune of approximately $6.5 million a year. And that comes, of course, from tax dollars. And the county executive, of course, has not increased taxes in the county since he's been in office. So he's figured out a way how to get that done to provide the services needed to maintain our mission to our community, which is Albany and the surrounding area. So that just throws you some numbers, even though I think you get the idea of what's going on in nursing homes. And then I'll pass the mic over now. So hopefully, I think during question and answer will help.
See the. Okay. See it. Can I still look? Oh, okay. Just hit this.
Do you want to?
No, I think that's okay. That's right. Hello, everybody. So I'm afraid, and I'll apologize in advance. I'm afraid that what I'm going to say is probably going to be as sobering as what Larry just shared with you. But I do think that it's important that people understand where our healthcare provider community is right now, because it is dramatically different than where we were in the past. And if you asked us 5 years ago if things were hard, we would have said yes, right, Larry?
Yes.
And we look back today and we think, wow, those were the good days. So I'll just start briefly with what is St. Peter's Health Partners. We're located in the capital region. We have hospitals in our system, a rehab hospital, and then we have the SPHP Continuing Care, which has a whole range of services. Okay. And I kind of just broke this down to go quickly between services we provide in patient homes versus services we provide in our homes. So out in the community, we have a whole range of care to keep people out of nursing homes as long as possible, if not forever. We have our traditional home health, certified home health, licensed home health. We have a PACE program, which is both an insurance plan for dually eligibles as well as a healthcare provider all in one. We have a team of nurse practitioners who go out to patient homes and bring primary care to them because they can't get to a doctor's office. They're homebound. We have our own home infusion pharmacy, medical equipment, including ventilator-dependent patients at home, community-based palliative care, hospice, Alzheimer's, coaching, and technology in the home. And then in terms of services that are provided in our home, we have everything from independent living retirement communities to adult homes with enhanced care.
Great.
You need to sync your slides. You're too behind.
No, it's not working. I'm hitting the button.
It's
Oh.
going
There you go.
Oops. Thank you for telling me that. I can't see it from here. So services that we provide in our homes include our independent retirement communities, our adult homes, including special needs, adult homes like our memory care. And then our skilled nursing facilities provide not just long-term care, but short-term subacute rehab, respite. And then even within long-term care, we have memory care units and our greenhouse model in Cohoes and Slingerlands. So that's just briefly the perspective that we come from. I would say this is really just a quick summary of what is different pre-COVID versus post-COVID. We always operated with workforce shortages and on very small margins. But what we were able to do with that very small margin as a not-for-profit is we were able to cross-subsidize programs. So that was the benefit of being part of an integrated delivery system, is someone would be having a okay year based on what was happening with reimbursement and services. And if you were having losses on one service line, you could cover it with gains on another. And in the end, you hoped everything evened out. We also could fund mission programs, so services that had no reimbursement or very little, and we could innovate. What a thing. Today, you look at healthcare providers and pretty much every sector, every service line is losing money. So when you're in that situation, you can't cross-subsidize, or the amount that you have to cross-subsidize from one area to another is very small. It really affects whether or not you can even do those mission programs for which there isn't reimbursement or there's very little. And the opportunities to innovate and do the stuff we all love to do and why we get into this field become tiny. Remember, I told you sobering, I did warn you. So they asked us to talk a little bit about the challenges that we face today and then what we're doing in response. So if I was to share kind of a quick summary, it really does vary by service line what the challenges are. The only thing that doesn't vary, and I threw at the top, is workforce. Everybody's suffering. But our PACE program has huge potential to help not only patients and families, but the government in saving money, but is largely a program that people don't know exists. So that's, excuse me, their biggest challenge. And hospice, you know, really as a state, we have so much to do. We're ranked 50th in the country in use of hospice. That's shameful. Every month, as just one hospice, there are 100 people a month who are referred to us when they are literally dying. And that means that their families had no support for 6 months before that, nor did the patient. So we have a long ways to go with hospice. And, you know, while I'm on that topic, I'm not going to miss the opportunity to say there largely is no payment for palliative care. And that is a huge opportunity for patients and families with serious illness who need that extra support. And we do know that when you provide that right, that it results in better outcomes and lower cost of care. So the government is totally missing out on that one. In our senior housing, the challenges that we see are that people come to us older and sicker. So they think that they're coming to us for independent living, but they really need the adult home level of care. And when they think they need the adult home level of care, they're really at the point that they need an enhanced level of care or memory care. And our home care agencies across New York State, certified home care agencies are 1/3 smaller than they were before COVID. Having a real hard time rebounding, just based on workforce. And I'm not going to even touch the nursing homes because he did a fabulous job of going through that. On the licensed home care agency, we're closing ours. When I started working for the Eddy in 1985, we had 400 home health aides. Today, we have 27. When I say to you, there's a workforce shortage, especially on the paraprofessional side, it's serious. So not to be too depressing, right? So where are we going from here? We kind of broke it into, I know you're ready. All right, everyone has got to go see Matt as a doctor afterwards for a script. So we broke this into, what's within our control and where do we need to come together as a village to solve this? And so, obviously, like everybody, standing on our head to do everything we can with recruitment and retention, doing everything we can to lower costs and find efficiencies so we can put money into just workforce. And then unfortunately, and you just should know that this is what every healthcare provider is forced to be thinking about today. What do we have to purposefully shrink, serve less, because we can't afford to subsidize the level that we are, and what do we have to close? And where do we come together as a village? And I know Al Cardillo is later on the agenda and he'll articulate this extremely well, but we have to stop saying that care is moving out of hospitals and institutions and into the community and then making funding decisions that don't match that. We have to stop doing that. There's a proposed Medicare wage adjustment for hospitals that will be phenomenal, and it's deserved, but it doesn't match what the nursing homes and home care and hospice will get. And that doesn't work. You can't fix one part of the system. It's like squeezing a balloon. It just pops out someplace else. And I'm going to end there because I think that's probably the summary. So thank you very much for having us today.
Okay, so tough acts to follow. So we drew straws before this. I got the long one. I get to be the total optimist and just say everything's going to be okay. Kidding, of course, but this may be a little disjointed. I will try to speak quickly. And I think it may be instructive, just give you a little sense of sort of my journey into this chair from way back when. So I'm an emergency medicine physician by training. I spent about 20 years, taking care of patients in emergency departments, working with hospital administrations, and had the luxury of working with Michelle a bunch, doing some innovative things. So it's been a great time, but some things I learned along the way. First, taking care of patients, being right in front of them is fantastic. It's heads down work. It's rewarding. It's wonderful. However, over time, you start seeing some patterns, and you often see that, there's a lot of things that happen in emergency departments, or you treat in emergency departments. You say, geez, if I only could have been ahead of this, if I could have been in the home, if I could have gotten ahead of it a little bit, could have avoided all this. And so you can imagine if you can get upstream, you avoid downstream problems, put simply. So over time, I kind of figured out that, the reason we do what we do in medicine is because it is not just because it's a fee-for-service system. It's true, it's a fee-for-service system, but it's the rigidity of that system that makes it so hard to change and do things differently. As it is, we can't change rates. We can't really change meaningfully in any given time frame the services we deliver. And I think, as Michelle just pointed out, if we're not funding home health, we're not going to get home health. So the rigidity there is a big problem. And as we move into opportunities for, capitated, like a PACE model, where you're getting a set amount of money, you're essentially uncoupling what services you deliver from the payment model, which means you can deliver services differently. You can be innovative. You can be more fluid in how you approach a patient's care because you're separating the reimbursement from the direct services. So in other words, the payment model doesn't dictate the delivery model. So that's a big piece of this. So it's sort of an aha for me. It took me about 20 years to get there, but I'm slow. I'll get there eventually. So as we move in that way, that allows us to start aligning payment models. And I know Jeff will speak to this. So with the service delivery models, as we get innovative, we do a better job of figuring out what's the best way to take care of one of our seniors who's living independently in the home. We can say, well, let's make sure we have a reimbursement model that makes that a sustainable service, to put it simply. So I'd say the first part is getting rid of that rigid fee-for-service system so that we have some agility as to what kind of services we deliver. Then payment models that align incentives. If we do a very good job taking care of folks in the home, we need reimbursement that recognizes we're keeping those folks out of expensive hospitalizations. Today, in a fee-for-service setup, if you bring palliative services, for example, into the home, it's very expensive relatively to do so. You're driving, medical professionals to a home to take care of a patient versus having, a clinic style. So it's not as efficient to deliver care in the home in some ways. However, if you're avoiding a hospitalization, there has to be some model that recognizes the cost savings. That's where value-based care and such comes into this. So as we get rid of that rigidity and get more, agility, and we start aligning the payment models with the services we want to deliver, to me, the next phase then is, well, how do we do that better and better, faster and faster for more and more folks in home? And that's really where we need to have a tech-enabled environment. So we heard this morning, wonderful conversation around consumer-directed choices and personal assistance in the home and the opportunity to leverage family members and everyone as part of the workforce. We have to do those things. However, we can't solve it purely with people. We also need to then make those folks as efficient as possible, and that's tech. So on the tech side, and I won't get into it too much, but for example, as was mentioned, working with the Apollo Care Group and Lou and VivaLynx. VivaLynx aggregates a lot of different technologies and allows us to introduce those into the home so that, for example, a caregiver who has to go off to work still has eyes and ears and sight into the home so that they could see what's happening with the senior that they're taking care of in the home. So it allows people to go to work. It allows them to take vacations. It allows them to do things that they would otherwise not be able to do. It also allows us to just do a better job of tracking what goes on in, as we describe sometimes, the 23 hours and 59 minutes of every day that goes by that a senior in the home living independently is not touching the rest of the healthcare system. Almost all of their time is spent in the home, and it is spent doing things we don't know about. Mostly good, I'm sure, but nevertheless. And by allowing us to, for example, see how much natural light do they get? How much physical activity they have? Are they interacting socially throughout the course of a day? Do we know if they're in bed? Did they ever come out of a bathroom? All those kinds of things. We can aggregate that and we can use that to say, hey, we know what's going on here. And we know, for example, that my mother or someone else needs a lot more physical activity. Provide opportunities to tell the family, hey, here's what's going on with mom, and somebody better call her, or we got to get her encouraged to get out of bed and move around. And if we could do those things, we'd be encouraging independent living. We'd be scaling up the opportunity to use our workforce the way we need to. And ultimately, what this all allows is us to break the cost curve, right? The bottom line is we're going to spend ourselves into oblivion in healthcare as the demographics change, as the care needs change, et cetera. So either we're going to consume all of our wealth, or we're going to cut all of our services, or we're going to cut the rates on those services and make them ultimately unsustainable. Well, that can't work. So what we really need is different ways to deliver care and payment models that support them. So I'll stop there and hand it to Jeff because he's going to tell you exactly how we're going to do that.
Wow. I can't wait to hear what I'm going to say. So I think the first thing that jumps out at me, when you think about the idea of the ongoing struggle of how we provide and pay for care, the demographics tell a story that's hard to ignore, right? In a few years, you're going to have more people over age 65 in this country than under the age of 18 for the first time in the history of our country. And that puts a lot of pressure on our current system, right? I don't think there's any slides. So, when you think about insurance in and of itself works based on the law of large numbers. You have more people paying in than you have people taking out of the system. That's how you're able to afford it. And the situation we're going to face shortly is that we're not going to have that. So to me, what that suggests is that we're at a period of transformational change in our healthcare delivery system. And we have to think about that in those terms. How do we change the paradigm? The encouraging part for me is I look at the pandemic, and we learned lots of things coming out of the pandemic. And I'll use MVP as an example. We, within days, became a virtual company. This wasn't a plan that we had. to work remotely. But out of necessity, it was something we had to adopt to. And sometimes, necessity is the mother of invention, right? It's a cliche because it's true. So in the situation that we have, I do think innovation is a critical part of where we go. Artificial intelligence is part of the answer. I know that there's a technology panel that's coming up. I think, show of hands, people have heard of ChatGPT, if you used it, maybe your kids have talked to you about it. Great scenario. So ChatGPT is just a single star in the AI galaxy. I heard that expressed the other day. Last week alone, there were over 1,000 different AI apps that were launched. Last week alone. So innovation is going to continue to come. We're going to use data to transform what we do, to gain efficiencies, to develop tools that are going to continue to move the system forward. Gordon Moore was the founder of Intel, and you may have heard of Moore's Law. It's basically technology doubles every 2 years. It's why your iPhone 12 becomes the iPhone 14 when your contract is up, right? The computer in your pocket is more powerful than the computer that landed people on the moon. Think about that, right? So technology really is a part of this solution, and how we embrace it as a system and use data to drive those decisions is really important. At MVP, we use evidence-based innovation and jobs to be done theory to go out and to hear from consumers, from partners, from providers, from employers, what their pain points are and where we can try and provide solutions as we go forward. And then we try to develop those solutions and build them to scale so that we can have a positive impact on how care is delivered. But there is no magic bullet, right? This isn't solved through one transaction. This is an iterative process that's going to continue to take a lot of hard work, right? From a lot of smart people over a long period of time to transform how care is delivered. Moving away from the transactional and episodic and building those quality outcomes that align incentives to build support for caregiver respite, which is a critical component. Looking at new innovative ways for how care can be delivered, how we can improve outcomes, how we can reduce costs is critical. But even going further, how do we build the relationships? At the end of all of these discussions, we have human beings. These are people's loved ones. These are families, right? And they need to be cared for, right? As people age, we have a generation that's trying to raise their children and take care of their aging parents. And the pressures to do that are real. They're significant. So being able to bring together funding from different mechanisms, access points, to be able to focus on wellness, build those public-private partnerships that allow resources to be shared, to improve coordination and communication are all part of the equation that move us closer to where we're trying to go. Addressing those social determinant of health needs further upstream, right? Before the problem becomes exacerbated and can't be managed. Those are all critical components, but it's not an easy problem, right, to solve. And that's, how we've gotten to this point. The challenge that I see is that continuing to put the focus on how we improve those outcomes, how we bring those resources to bear, will ultimately move us closer to the solution. And so it's something that every day, that's what I get up in the morning. It's what I think about, right? That's my why I come to work. It's what motivates me. And I have a team of individuals whose sole goal is to go out into the communities and to talk to people, to build those relationships, to break down those barriers, and to help people with two things that make them very emotional: their health and their finances. So it's a great end result that we're working on, but there's a lot of work left to do. And sessions like today, just you look around the room for all the people that are here and engaged and bringing their time and their talent to these challenges. It tells me that we're in good hands and we're headed in the right direction.
Thank you so much. Thank you. If I can pull everything together here that I'm hearing. You know, AARP in New York State has almost 2.5 million members. And what we do in the New York State office is work on advocacy and policy every single day. And the purpose of it is to make sure that people can make decisions about their own lives as they age. And that's why everything that we're hearing right now is so important. I just want to give a shout out before I go further to Robin Haberman. I think she's in the back of the room. She's our Associate State Director who covers all of northeastern New York from the Hudson Valley up to Plattsburgh. So if you want to get to know her, please do, because I think she'd like to get to know you all, because you are the frontline advocates that can help us trying to accomplish what I'm hearing today, which is quite a huge agenda. You know, we know that people want to stay in their own homes, but at a certain point, they no longer can. So I really do appreciate Larry's perspective here, because very often we get kind of slide over that and forget that there's a purpose to institutional care, and that is so very important. But we also, I'm really hearing what you're all saying about how do we keep people in their homes. And Michelle, what you said about the worker shortage, I think is so appalling. I mean, I think all of us, I looked around the room, everybody's jaws dropped on that one line. So what I would say to all of you, and as my first prerogative is moderating this panel, and then I'm going to go to questions from the audience. But for any of you who want to jump in now, and you've kind of hinted at this, like, what is it that New York State needs to do right now? And I know, Michelle, you kind of wrote this into me about the master plan on aging, and you all heard a presentation on the master plan on aging this morning. So that is our opportunity. That is our inflection point. So how do you all see trying to insert what needs to get done in New York State through that process? So who would like to go?
I'll start, but please jump in. I mean, I think, you know, we've talked about it a little bit here today. When we make decisions about how we're paying for healthcare, it can't be in a bubble. You can't fix hospitals without thinking that you also have to fix nursing homes, home care, and hospice. You can't. It all goes together. Patients can't get through the ER, out the hospital, and to where they need to go if those other services aren't there to catch them. And that's what's happening today in the ED. That's why people are backed up and they're there for hours. So you can't just address one part of the system. If COVID taught us nothing, it's that how everything is so interconnected. And then just to reinforce what Matt said, we can't survive on what we're being paid today. That was pretty clear. I mean, I think Larry said it extremely well. It's not working, doesn't, you know, and so, and yet we know that the system can't afford to pay us more. So we have to get to a point where providers aren't paid this way. We have to be able to share in the savings that we've helped to produce. And that's the only way that we're going to survive and be here to provide care for people in the future.
I'll echo that. I think one of the things that a lot of insurers are currently looking at in value-based contracting is how do you have those shared savings and use it to reinvest in the system and in the patients. The whole point is to make sure that wherever a patient is in the continuum of care, you're able to provide services that meet their needs. Otherwise, what is the point, right? So I do think that that's a big focus, I know, for many of the insurers out there currently, is how do you accelerate value-based savings? How do you contract in ways that recognize that the costs that are saved from improving outcomes need to be reinvested in order to keep people well and keep people healthy? The business of paying for sick care is a race to the bottom. Right? It's not sustainable. So we have to change that paradigm. And I think those are just some of the beginning salvos and how do you start to change that system?
Well, the only thing I could say is that legislators, government, know how to take care of seniors when they're running for office. But once they're in office, they don't know how to do a budget to take care of seniors.
Really not much to add. I think. Why ruin that?
So I'd love to get questions from the audience. We have just under 10 minutes left, right? So anybody? I see somebody out there. We have a mic to bring over to them, or I lend a mic? Then would you mind standing up, ma'am, please? Thank you. And could you identify yourself too, please?
Okay, can everyone hear me? Okay, a suggestion I have is that when homes are constructed, they're to be constructed so that they're handicap accessible. So as people age, they have a bathroom on the first floor, there's no steps, they have a walk-in shower, and things like that. So when you get older, like Stanley living in that house with those stairs made me cry. They really made me cry. He needs a nice handicap accessible residency. And that's one of the things I think should happen. I don't know how you do it, but I think it would be a good idea.
Well, I couldn't agree with you more. AARP couldn't agree with you more. We actually have worked on two different pieces of legislation, one for inclusive design, and then there's another standard called visibility. And so you're right. And if you're very interested, see Robin in the back, because she's organizing volunteers to work on those issues. So
And
I
just
really
wanna make
appreciate your
another
comment.
That lovely man from AARP that suggested that they have the National Guard come in to help with home health aides. I think that's a wonderful suggestion by AARP. And I think that it can be utilized. It can be utilized now. All I've heard all day is that you are in a crisis. We have to address this crisis. We can't wait till next year, next month, or 5 years. We're in the crisis now.
Thank
Thank
you
you.
so much.
When we began this 28 years ago, I was part of a group called the Capital Area Consortium on Aging and Disability. And it was a wonderful group with a lot of providers. The Eddie had David Howells, I believe, on the board, and a number of providers, doctors, and one other physician who was a home care only physician, Dr. David Hornick. He has a home care only practice. He's now retired. His wife, Roberta Miller. We've worked with them. They've worked with our clients. He designed his own home with what's called universal housing design. He'd be happy to give you a tour, but he did this 30 years ago. And it's now fully handicap accessible. And he has been living there as an independent adult, and now he can age there throughout his lifetime. Universal housing design's been around a very, very long time. We did Ida Yarborough apartments. We did 3 apartments in the south end of Albany as universal housing design apartments, cracks in the ceiling covered by tiles until the individual needed a Hoyer lift, and it would take them right out of bed into the bathroom, all designed in, countertops that lower. So this is something that absolutely needs to be part of this. And Dr. Hornick is willing to talk to anybody that's willing to listen about his home and the universal housing design. And he's very anxious to share his ideas on this as well. So how do we take, because it's new housing stock is a whole different game. And the governor's plan is to build new housing, but people live in their own home. They've been there for 50, 60, 70 years. How do we bring the services in and create environments in their own home that can let them live there and stay well, stay healthy, and allow the family and the caregivers to participate?
Okay, more questions.
Well, that's a question.
Oh. Well, I would just say that we've had, AARP has had a number of pieces of legislation around this, and Lou would like your support. And as I said before, if others are interested, we have had pushback, and we keep pushing it, but there's other interests at heart that aren't always in agreement with what you're saying, which I couldn't agree more on.
Dr. Miles?
Did you want to answer that?
That on? Yeah. I think that was a prompt from Lou. So, yeah, I think just starting with the idea of home design, clearly we can't redesign all the homes that exist now, but retrofitting is a huge factor, and we need to make spaces that are safe for seniors, right? And then beyond that is, getting back to the technology part of it is, we have to be able to monitor and track things in the home such that it's not as a replacement for anything, but as a support mechanism for what is already a dwindling and insufficient workforce. And I don't care if that is including every visiting nurse, home health aide, et cetera, but also every son, daughter, or worried family member about their seniors. We have to make it easier for people to take care of other people. And that's a big part of that is technology.
I thought I saw another question on this side of the room. Did I, or was it taken care of? Anybody else? Oh, Peter, I'm so sorry.
So when I first started doing what we are calling elder law today, New York was a pioneer. We had a philosophy that we had to take care of people. When other states stuck to a $2,000 asset exemption, we had 8 and 9 and 10, and now we have 30. But we also suddenly decided that only people who could not perform 3 activities of daily living instead of 2. Have we turned away? Have we somehow become like Texas and Oklahoma in the care that we give to the aged? And what's behind this? Is it only budget? We can solve budget problems. So what's happening?
I guess that's on me. So I'll give you there's a few forces here. One is, there are more and more folks to take care of. That's one. The other is with all of our advances in technology and medicine, we have people living a lot longer with illness. So, I mean, you take just for example, bypass surgery, cardiac stents, et cetera, and what that's meant for folks to continue to live with a heart that otherwise would not have sustained them. We have more and more people who need our help, and they're complex. So that's a big part of it. So in other words, the demand for services is hugely increased. The supply of those who can take care of folks is not keeping up.
One more piece of legislation. AARP works on a lot of legislation, but we've been working on this Credit for Caregiving Act, which would actually give caregivers a tax credit. So if they were making improvements in their home, the average caregiver pays over $7,000 a year out of their own pocket. That's a big hit to moderate income families. And so we really all need, and I appreciated what you said before, Matt, because we've got to support those caregivers, because without them, we're going to end up with a whole bunch more people that are going to need institutional care. If we don't get them, I love the way you said, we don't get them further up the stream. So I don't know if we have any other questions. Michelle, did you want to say one more thing? And
I was going to say, I think part of the issue is just that it's what we spend our money on. I would venture to say, if we were the payer, we would spend money very differently. We would provide services that prevent people from using the most expensive settings. We know how to do it. We can't do it in today's reimbursement system. That's what has to change. We're wasting money over here and we're short over there.
Just one other point, I think, when Medicare and Medicaid were rolled out, right, in 1965, the life expectancy was about 62 years old. That's why the entitlement kicked in at age 65, right? So that's part of the equation that's changed. Our life expectancy is much longer now. And to Dr. Miles' point, people are living with disease states much longer. Advances in medicine and pharmacy have helped to improve that. But it creates a new downstream issue, and it's how do we care for people with these disease states as they age, and the needs are different, very different than 1965. The real first major change to Medicare was rolling out Part D. When did that happen? 2008, right? Like not a lot of change to support the changes in society. And so I think the challenge, when we talk about transforming the healthcare delivery system, is advocating for the realities that we face. You heard from everyone on the panel say that the current system needs help, right? We're at a cliff. These numbers don't lie. They tell a story, and that story is alarming. So it really becomes, what is our will to do something about it? And that to me is, again, it's an advocacy opportunity. It's an outreach opportunity. It's the collaboration of folks in the room today to have these discussions and to challenge ourselves and say, what else can we do? How can we do better? And I think there's a will to do it. There's a need to do it. So, the next number of years are going to be very exciting to see how these things change, because it's required.
Thank you all very much. I think we've run out of time, and I'm so sorry about that. I really feel very privileged to have been on this panel. I don't know if you all noticed, I was taking a lot of notes. I learned a lot, so thank you.
Thank you all.